Thorax Chapter 18, the Elbow and Forearm Complex. Structure and function of the elbow and forearm. So joints of the elbow and forearm, we have our humeral ulnar articulation, which during open chain we have our concave ulna moving on our convex humerus, and during closed chain we have our convex humerus moving on our concave ulna. We also have the humeroradial articulation, which is the articulation of the humerus with the radius, but this is not our articulation that occurs for elbow flexion and extension. While there is movement that happens there, our primary articulation is going to be the humeral ulnar joint. Ligaments of the elbow, we have our medial collateral ligament or ulnar collateral ligament and our lateral collateral ligament that we need to look at ensuring are protected. Forearm joint characteristics. We have a proximal radial ulnar articulation and a distal radial ulnar articulation. Remember that our radial head rolls over our ulna, so our radius is the bone that moves. Muscle function at the elbow and forearm. So these are the primary actions that we're looking at. Elbow flexion, we have our biceps brachii, which remember is best resisted in a forearm supinated position. Our brachioradialis, which is best resisted in a forearm neutral position, and our brachialis, which is best resisted in a forearm pronated position. We have elbow extension that's caused by the triceps. Forearm supination is caused by supinator, as well as biceps brachii being a supinator, and then brachioradialis contributes to forearm supination when the forearm is in a pronated position. It does not supinate past neutral. Forearm pronation is completed by pronator quadratus, pronator teres, and then brachioradialis. When the forearm is in a supinated position, it will act as a pronator, but it does not pronate past neutral. Normal function of most ADLs requires a functional arc of at least 100 degrees at the elbow, and the most functional arc is going to be 40 to 140 degrees. This should be a review at this point, but we know that our wrist flexor muscles attach to the medial epicondyle, and our wrist extensor muscles attach to the lateral epicondyle. And so because they cross the elbow, if we want to fully lengthen them, we have to extend the elbow during stretches, but they cross at too short of a line of pull to cause any motion at the elbow. Referred pain into the elbow region is typically a result of nerve disorders. So we can have referred pain from the ulnar nerve that gets compressed at the cubital tunnel, or it can also become compressed at the heads of flexor carpi ulnaris between those heads. The radial nerve can become compressed in between or underneath extensor carpi brevis, and it can also become compressed under the supinator muscle, and then the median nerve can be compressed between the heads of pronator teres and in the carpal tunnel. Compression of any of these nerves can present with elbow pain, and oftentimes soft tissue mobilization of the muscle that is compressing the nerve can help to alleviate those symptoms. Management of elbow and forearm disorders and surgeries. Elbow joint hypomobility, so decreased motion. It's going to be caused by things like rheumatoid arthritis, degenerative joint disease, trauma. There's a box 18.1 on page 652 that gives you an outline of traumas that can cause elbow hypomobility. We can also see fractures as being a cause of elbow hypomobility. The radial head is the most common portion to be fractured in the elbow and forearm as a result of a Fuchs injury in adults. Dislocation can also cause hypomobility and post-immobilization contractures. Things that patients won't be able to do when they have elbow hypomobility can include pushing up from a chair to stand, restricted hand-to-mouth activities like eating or drinking, and difficulty turning a doorknob. Common impairments. During the acute stage, we will see joint effusion or joint swelling, muscle guarding to protect and restrict motion at the area, and pain. During the subacute and chronic stages, we will typically see range of motion restricted in a capsular pattern. So how do we treat it? During the maximum protection phase, we're going to educate the patient on the expected progression of their recovery and participating or modifying activities as appropriate. We want to reduce the effects of inflammation or a synovial effusion and protect the area. Frequent periods of controlled movement within a pain-free range should be performed in order to reduce those effects. and grade 1 and 2 mobilizations can be utilized. However, mobilizations are contraindicated when the patient demonstrates an empty end feel for elbow flexion or extension. So if pain is the limiting cause of their range of motion and we have that empty end feel, we don't want to perform mobilizations at the elbow. Maintain soft tissue and joint mobility through passive range of motion and active assistive range of motion, and perform multi-angle isometrics within that pain-free range. We also want to maintain integrity and function of the related areas, so we will implement shoulder exercises, wrist exercises, hand exercises, as well as scapular exercises as needed. During the controlled motion phase, we want to increase soft tissue and joint mobility with light stretching, low intensity, long duration, low load, and gentle range of motion activities. Passive joint mobilization techniques can be utilized for grade 1 and 2 mobs. We want to improve joint tracking of the elbow, and this can often be accomplished with mobilization with movement, where either the therapist or an external structure can apply a mobilization force that helps to realign the joint as the patient provides the movement of elbow flexion and extension. We also want to improve muscle performance and functional abilities with active and low load resistance exercises in both open and closed chain positions. Develop muscular control, endurance, and strength. As the patient improves, we want to adapt their exercises towards functional activities so that we can progress towards that return to function phase, and include shoulder, girdle, wrist, and hand exercises in the program. For return to function, we will continue to improve muscle performance by progressing strengthening exercises and using exercises that replicate the demands of daily life. We want to restore functional mobility of the joints and soft tissues through vigorous stretching as needed by this phase of the game, and promote joint protection with activity modification when chronic conditions are present. Surgical interventions for the elbow. So we'll talk about a couple here. The first one's going to be radial head excision or arthroplasty. So it's where they go ahead and remove the radial head or give you a prosthetic radial head. Reasons they would do this would be a severely comminuted fracture or chronic synovitis. You can dive into the textbook for the procedure, but basically they go in and either cut out the radial head or put in a prosthetic radial head. Complications that can be seen following this procedure include radial tunnel syndrome, where there is radial nerve involvement, persistent pain, and a sense of instability. Post-operative management is going to follow guidelines of a protocol as indicated, but trying to restore strength and functional mobility to as high of level as possible. Our goal is a stable elbow with pain-free movement within functional ranges. We likely will not increase the range of motion to beyond that functional arc of at least 100 degrees, but our goal is to get them at least a pain-free functional arc. Question time. So during the protection phase of rehabilitation for a patient with elbow hypomobility, which intervention is most appropriate to prevent contracture formation? Pause now if you need time to think. Hopefully you guessed gentle passive range of motion exercises within the patient's tolerance. Another surgery that we may see is a total elbow arthroplasty or a TEA. Reasons that somebody may get a TEA are advanced RA, patients with debilitating late-stage arthritis, non-union distal humerus fractures, bony tumors, osteonecrosis, which is bone death, patients with dysfunctional instability, so instability that is progressed to the point where they have lost function, and patients who have had unsuccessful previous surgery and are over 65 with low functional demands. So they can't be one of those really active older people. With a TEA comes risk of complications. Intraoperative, so during the procedure, complications that can occur can be fracture, component malpositioning, or ulnar nerve damage or irritation. Post-operatively, we can see the risk for infection, joint instability, triceps insufficiency because of the way that the procedure is performed, and wound healing. Post-operatively, we are going to understand that these patients are going to be immobilized. Their position is going to depend on the surgical approach and the implant design and the surgeon's preferences. That immobilization period can last from 1 to 2 days to several weeks for immunosuppressed patients, and again is going to be based on the surgical or surgeon's preference. During the maximum protection phase, which is approximately 4 weeks long, we want to focus on control of inflammation, pain, and edema, early passive range of motion, and active assistive range of motion as tolerated. However, the initiation of range of motion is going to be delayed in unlinked total elbow arthroplasties. We want to maintain mobility of the surrounding joints, so ensuring that we are doing work for the shoulder, scapula, wrist, and hand. We'll want to regain motion of the elbow and forearm, and so we will work, again, our passive range of motion into active assistive range of motion for elbow flexion and extension, but also forearm pronation and supination, and minimize atrophy with setting exercises as appropriate. Moving into the moderate and minimum protection phases, it's important to understand what your precautions are. So box 18.5 on page 662 highlights the specific precautions for total elbow arthroplasties, and that might be a good box to familiarize yourself with. I'm going to highlight some of the most important ones through here. So approximately 4 to 6 weeks after post-op, soft tissues have healed enough to start stressing, so we want to apply stretches appropriately. By 12 weeks, only minimum protection is needed, so we can kind of work through our moderate protection into our minimum protection phase pretty quickly. We want to increase range of motion of the elbow as best we can and regain functional strength and muscular endurance. However, we have to take those special considerations into mind. High load progressive resistive exercises and heavy lifting during home work activities and recreational activities that place high loads on the upper extremity are not allowed after the TEA. So there might have to be a modification of activity participation that the patient has to undergo if they've had to have a TEA. The patient will have a maximum lifting limit of 5 pounds for repetitive lifting and a maximum lifting limit of 10 to 15 pounds for a single lift following a TEA. And so those are considerations to keep in mind, not only to educate your patient on, but also in developing your treatment plan and staying within what they are allowed to do. Myositis ossificans is also known as heterotopic ossification, and this is the formation of bone in an atypical location in the body, typically within the muscle. It most commonly develops after a fracture, but it can also be associated with traumatic brain injuries and spinal cord injuries, and delays in intervention also increase the risk of heterotopic ossification. Patients will present with a restriction of a joint motion after they had an inciting trauma, so something had to have happened that caused an injury, and subsequently after that they develop these range of motion restrictions. When we palpate, we can perceive a locking sensation at terminal extension or terminal flexion, and it typically onsets 2 weeks after the initial injury and presents with swelling, warmth, and pain with a gradual loss of elbow range of motion. It's managed through aggressive passive stretching. It is not managed through aggressive passive stretching because that is contraindicated. The more we stretch it, the more we can promote further bone development in that atypical spot. And so we need to have gentle range of motion activities that don't promote further bone growth. Surgical excision may be necessary depending on how much ossification has occurred. Our goals are to restore functional range of motion and strength, whether it's treated conservatively or operatively, while avoiding aggressive passive stretching. Overuse syndromes at the elbow are going to include our lateral epicondylitis or lateral elbow tendinopathy or tennis elbow, and our medial epicondylitis or medial elbow tendinopathy or golfer's elbow or little leaguer's elbow, depending on which name you want to refer to it as. This is going to be where we see excessive repetitive use or eccentric strain of the forearm wrist muscles, creating that pain, inflammation, and subsequent weakness. These patients will present with gradually increasing pain with hand and wrist activity, pain when the involved muscle is stretched or when it actively contracts. So if it's our wrist extensors, if we stretch them into wrist flexion or they have active wrist extension, they will have pain. Vice versa for the wrist flexors. We'll also see decreased strength and endurance in the local and proximal and distal musculature because as patients experience elbow pain, they tend to use that extremity less, and so we see weakening happen throughout the extremity. Common activity limitations and participation restrictions are going to be whatever their provocative activities are. So if it's typing or if it's playing tennis, if it's playing golf, if it's working with their power tools, whatever causes the pain is going to be their biggest activity limitation or participation restriction because it's an overuse syndrome. And repetitive motions, again, it's an overuse syndrome. During the protection phase, we're going to work to decrease pain through the use of orthotics or immobilization as appropriate. We're going to provide patient education on relative rest, so that doesn't mean completely resting, but avoiding activities that cause pain and resting from those activities. So taking rest from the provocative things, and utilization of ice as the patient is comfortable with. We want to develop soft tissue and joint mobility, so we'll utilize soft tissue mobilization, passive stretching, and nerve glides in this population to help manage their symptoms. During the, I'm guessing this is supposed to be moderate protection phase, we want to provide maintain upper extremity function. This might be the maximum protection phase still. I'm not sure on this, and so ask me in class and I will let you know what this slide is supposed to say. I might be able to let you know as soon as I get to the next slide, but we want to maintain upper extremity function with active range of motion to all upper extremity joints and resistive exercise proximal to the elbow. So we want to not give them resistance at the elbow or the wrist that's going to end up being provocative and irritating to the musculature that's involved, but we do want to provide resistance exercises proximal to the elbow, so looking at the shoulder, the scapula, and even the thoracic and cervical spine is indicated. Yeah, that last slide was still maximum protection phase. So during our controlled motion and return to function phases, we want to increase muscle flexibility with manual stretching. So we've gotten to the point where passively stretching the muscle shouldn't increase the pain, and we want to stretch it as much as we can without increasing the pain, and utilize soft tissue mobilization. We may restore joint tracking of the radial ulnar joint with mobilization with movement, which again is providing a mobilization to the bone that helps better align the joint as the patient moves through the range of motion that they are restricted in. We're also going to improve muscle performance and function through dynamic resistance exercises through a pain-free range of motion. Again, remember that active contraction of the irritated muscle increases pain, so we need to work them in the range that doesn't increase pain so that we can allow the tissues time to heal and not re-exacerbate the issue. We'll start with low intensity and higher repetitions to build endurance and progress to more intense resistance as tolerated. We want to emphasize eccentric activation of the involved muscles to get the greatest and most efficient outcomes, and we'll incorporate functional patterns to emphasize stability as the patient progresses. We'll provide patient education on self-management and activity modification so that the patient is able to manage this if their symptoms return. Exercise interventions for the elbow and forearm. So we're going to talk about these slides pretty quickly because we will go through them again in lab, and you guys are going to implement them for patient cases. And so I want you to have at least a little bit of an understanding, but understand we will practice these things more in lab. So if we're increasing flexibility and range of motion, we have manual, mechanical, and self-stretching techniques. We will stretch the elbow flexors to increase elbow extension. We will stretch the elbow extensors to increase elbow flexion. We will stretch the forearm pronators to increase forearm supination, and we will stretch the forearm supinators to increase forearm pronation. We will teach self-stretching techniques, remembering that we need a straight elbow to get full elongation of our wrist flexors and wrist extensors because of their origination from the medial and lateral epicondyle. Isometric exercises, we can perform multi-angle isometric exercises at varying degrees of elbow flexion and elbow extension, isolating key musculature, especially depending on forearm position. We want to apply resistance at the distal forearm, so that way we are maintaining focus on the elbow musculature and not carry over into the wrist musculature or engagement of the shoulders as a compensation mechanism. Angle-specific training, we can simulate positions of anticipated functional use and do isometric training there to help promote the stability and muscle firing that's needed. Alternating isometrics and rhythmic stabilization. So if you'll remember, alternating isometrics would be applying resistance in one direction for that 3 to 5 second hold, and then that gradual, progressive, slow shift to resistance in the other direction for a 3 to 5 second hold. Whereas rhythmic stabilization is the quick change in resistance to make the patient respond. These can be performed open chain with that manual application like I just described, or things like using the body blade, which we have in lab. We can also do closed chain alternating isometrics where we have the patient weight bearing and those resistances are applied through the trunk. Dynamic strengthening and endurance exercises. It is very important to remember as we are selecting our exercises and instructing patients on how to do them, and what we need to emphasize is that chronically inflamed tendons benefit from eccentric contraction in the pain-free range of motion. And so where we can target and isolate eccentric contractions as best as possible will get us the best outcomes for our patient. When looking at elbow flexion, we want to make sure that we are resisting biceps brachii, brachialis, and brachioradialis by alternating the position of the forearm from supinated to pronated to a neutral forearm, respectively, for how those are listed. We also want to do elbow flexion in standing and in supine because we have different levels of resistance. When we are in supine, we are only having to fight gravity from 0 to 90, and our muscles are in a slightly different position for our line of pull. When we are in a standing position for elbow flexion, we are fighting gravity from 0 all the way up through elbow flexion. And so making sure that we start them in the best position for stability and strengthening, but also progress them to the most appropriate positions. And then when we are resisting when we're providing resistance exercises for elbow flexion, also remembering to resist the long head of the biceps, we have a contribution to shoulder flexion through the long head of the biceps. And so doing elbow flexion with shoulder flexion activities can help to focus work at the biceps. Also, we can focus work at the biceps by doing our elbow flexion with supination activities, which we'll talk about some examples of here in a minute. Elbow extension, remember we can do it in prone versus supine versus seated. What's going to be the best position for the patient, what's going to provide them the best resistance, and what's going to require the safest level of stability at the shoulder, because all of those positions for appropriate elbow extension are going to require varied shoulder positions. Utilization of a weight versus a band, we can do either one, but which is going to be safer for the patient, making sure that we're factoring that into our considerations. And long head of the triceps with elbow extension, remembering that long head contributes to shoulder extension as well, and so we can do elbow extension with shoulder extension to get full activation of that musculature. When looking at pronation and supination, if we're using free weights, or resistance bands, we want to ensure that the forearm is supported so that we can focus the movement at the forearm for pronation and supination, and not a compensation at the shoulder with internal and external rotation. We also want to incorporate functional strengthening. Remember things like turning up a radio knob, opening a door, sometimes opening a jar, but drinking your drink. Those things all require pronation, supination in a functional manner, and so we need to do functional training for those activities as well. Wrist flexion and extension, these muscles cross the elbow and wrist, so we need to strengthen them where they move. We need to strengthen them primarily at the wrist, even though they cross the elbow, and so that's why we need to focus on wrist flexion and extension even when we're treating patients with elbow dysfunction. Wrist stabilization is an important emphasis of elbow and forearm exercises, so if I'm performing an elbow exercise or a forearm exercise, having a neutral wrist is a very important component of that exercise, not only for ensuring that I can't compensate, but also for promoting the stability I need for functional carryover. As our patient progresses, we'll move them from straight plane movements to diagonal patterns, and then combine our pulling motions and our pushing motions. So combined pulling would be resistance band pull-ups, modified pull-ups or chin-ups, resisted pulling motions, and functional pulling. And remember we talked about pulling like starting a lawnmower. We elbow flex, we shoulder extend, and we supinate, and we can do that with a resistance band. We can do any of those functional movements where we have those combinations with a weight or with a resistance band as appropriate to help get the patient back to where they need to go. Same for combined pushing motions. We have a military press, a bench press, a modified push-up, chair push-ups, a upper body ergometer, and functional pushing all can be utilized to mimic those functional combined pushing motions, which engage multiple areas of musculature that we want to ensure we have appropriate muscle firing and stability of. We can also progress with the use of plyometric training, which remember is that stretch shortening where we have the quick stretch before we concentrically contract the muscle. So things like the quick change resistance band or ball tosses or bouncing a ball with a racket are all going to help give that plyometric input to the elbow and forearm. Simulated tasks with activities are going to give our functional components. So we can break it down into part tasks. So if this is pushing up from a chair we're struggling with, we don't have to do the entire process of pushing up from a chair. We can start by just trying to de-weight our bottom from the chair as we push up with our forearms to help get that closed chain elbow extension, and break it down into the part that the patient struggles with the most before we put it together with the whole task. So we do part task to whole task training of simulated functional recreational activities to build the strength and endurance that the patient needs to safely perform them. And then balance training is very important because of the risk of radial head fractures as caused by fall on an outstretched hand injury. And so if a patient is experiencing elbow dysfunction as a result of that fall originally, we need to do balance training. If a patient is a fall risk, they are at increased risk of further elbow dysfunction as a result of that fall, and so we may also incorporate balance training. We're going to finish up here with a couple of questions. I'll let you know when to pause it to give yourself time to think as I read through them. And then other than that, for class, make sure that you look through the elbow chapter for the exercises and stretches that we will apply in lab, and prepare to look through a patient case and complete a treatment plan for that patient. So how does a total elbow arthroplasty affect the effectiveness of treatment interventions for elbow rehabilitation? Pause now if you need time to think. It often leads to increased pain and instability, necessitating more conservative treatment approaches. Total elbow arthroplasties are not surgeries that are quickly jumped into, and they are only done when the patient doesn't really have any other option, because they don't tend to have the most successful outcomes. They do often lead to increased pain and instability, and so we have to be very conservative in our treatment approach. It can be very slow going, and those are things to consider with a TEA. Which of the following is the appropriate progression of exercises for a patient recovering from elbow surgery, starting from the early stages of rehabilitation? Pause now if you need time to think. So I'm going to start then with isometric exercises so that we're not passively stretching those or excessively stretching those tissues that need to heal through passive movement. So we start with isometrics, then we move into Forearm, then active range of motion, then to strengthening exercises. A patient presents with lateral elbow pain that has persisted for several months as a result of repetitive use of power tools. The patient reports aching in the forearm and transient sharp pain when gripping an object tightly. The supervising PT completed the examination and recommended a treatment program addressing chronic lateral epicondylitis. What are the most appropriate intervention strategies for this patient? Pause now if you need time to think. So we want to use heat therapy prior to the activities to improve blood flow and increase tissue extensibility before we use them. Then we want to practice using the power tools with the review of proper ergonomics and body mechanics so that we can train the patient on the appropriate functional positioning and any potential modifications that may need to be made, and also build the endurance in the musculature that is demonstrating the impairment. And then we'll use ice after to reduce inflammation.